بسم الله الرحمن الرحيم. السلام عليكم جميعا أعزائي الطلبة. إن شاء الله عندنا محاضرتين راح نبديها which include poisoning in children, chemical and drug poisoning in children. I'm Dr.Murtadha Yassin, lecturer in Department of Pediatric in University of Basrah College of Medicine. So we start. Learning objective of this lecture is first to identify that poisoning is a common avoidable cause of harm to children. The second is to identify the clinical circumstances of a high index of suspicion required to diagnose a poisoned child. Third, to identify a common toxidrome, and then we know what is the definition of toxidrome. And lastly, to understand a plan of action which do in a poisoned child, which include 4 main steps: A, supportive care; B, decreasing absorption of the poison; C, enhancing elimination of poison substance; and D, neutralization of the toxin. So start with a definition, general definition. So what is a poison? In a common usage, poisons are chemical or chemical product that harmful to human. And more precisely, a poison is a foreign chemical, xenobiotic, that is capable of producing a harmful effect on a biological system. What is a toxin? It originally referred to a poison of animal or plant origin. Toxicant is the currently preferred scientific term for all poisons. Now we come to the definition of a toxidrome. Toxidrome is the association of several clinical recognizable features, signs, symptoms, phenomena, or characteristics which often occur together so that the presence of one feature alerts the physician to the presence of other. Causes of poisoning in relation to the age. We have 2 age peaks for poisoning. The first, unintentional, which is called also accidental poisoning. This mainly occurs in less than 6 years of age, and in this the male is more than the female regarding the sex. The second, intentional, which is mainly more than 12 years of old, adolescent, and in this age group the female more than the male, the incidence. And the third cause is the iatrogenic causes of poisoning. Poisoning is number 1 cause of injury death in United States, which is unintentional. And adolescent is the third leading cause of injury related death, which is intentional. 50% in less than 6 years old, almost all unintentional. And the method of poisoning is either ingestion, which constitute the majority of exposure, and the second, the minority, is the dermal, inhalational, and ophthalmic routes. Type of poison substance. 50% is non-drug substance like cosmetic, personal care item, cleaning solutions, plants, and foreign bodies. The second type is drug, remainder of exposure, which include analgesia, topical preparation, cough and cold product, and vitamin. Most common is the vitamin. Now we come to the clinical scenario. So we pass to how to manage a child with poisoning. A 3-year-old child was brought by his family suffering from acute attack of drowsiness and unsteady gait. His past history unremarkable. Apart from his grandmother was complaining from some psychological disorder. On exam, the child had abnormal pupillary reaction. There was no fever but tachycardia with normal other part of the exam. So what is the possible diagnosis? And what is the initial medical care? And how would you treat this condition? So, first, how we diagnose a case of poisoning. So, we have to have high degree of suspicion. So, how we suspect poisoning in children? There are many circumstances. First, historical feature such as age of the child, as we mentioned, mainly toddler or adolescent. Acute onset of symptoms without a prodrome. So the family come and tell you the child is completely healthy before and then develop acutely these symptoms. Sudden alteration of mental status. Fourth, multiple system organ dysfunction. High level of household stress. So in these circumstances we suspect that this child have poisoning. How we manage child with poisoning? First, initial medical care. This is very important step in the management. Supportive care, which include airway, breathing, circulation, what we call ABC measures. This is very vital for the management of poisoned child. Second, we have to take a targeted history and physical examination. And then the third is the treatment plan, which include decontamination of the poisoning, enhanced elimination of the poison, and antidote neutralization. In the history and the examination, we have to focus on these aspects. First, what toxin medication was taken? So what type of toxin? How much was taken? So the dose. What time is taken exactly? Exact the time. Who was the witness? And what medication or toxic substance was available to the child? The other is the presence of symptoms and the past and social history. In physical examination, we focus on the vital signs, very important: blood pressure, pulse rate, temperature, respiratory rate. We concentrate on conscious level, mental status, and the pupil, the size, reactivity, nystagmus, skin, bowel sound, and odor. These findings we might suggest a toxidrome as an association of clinical features, signs, symptoms, and so we know the exact poisoning. Lab investigation, we do in general full blood count, blood gas analysis, renal function test, electrolyte, blood sugar, serum and urine for toxicology, screen, and special investigation as indicated as ECG, radiology. The first in treatment plan is gastric decontamination. We discussed this, how we do gastric decontamination in children. We have main 5 types how we do gastric decontamination. The first, induction of emesis. Second, gastric lavage. Third, activated charcoal, single dose activated charcoal. fourth, cathartics, and fifth, whole bowel irrigation. Now we discuss each point to know what is the drawback of this point and what is the benefit of this point, and it's beneficial in children to use or not. So, induction of emesis. How we induct emesis? We give a syrup of ipecac. Emetic alkaloid work on CNS and the gastrointestinal tract. After a review of the evidence and the assessment of the risk and benefit of ipecac use, the American Academy of Pediatrics and the American Academy of Clinical Toxicology and the American Association of Poison Control Centers have all published statements in favor abandoning the use of ipecac. So, it's no of value to use syrup of ipecac in children. The second is the gastric lavage, is the way of gastric decontamination. The drawback of this procedure is time consuming and it's painful to the child. It induces bradycardia via vagal response to the tube placement. Also delay in administration of more definitive treatment, which is activated charcoal. Only remove a fraction of gastric content, so it is no longer recommended for childhood. The main way of decontamination in children is a single dose activated charcoal. It is potential useful method of GIT decontamination. Complex molecule with large surface area bind many poisons. And there are substances really poorly absorbed by activated charcoal. For example, heavy metal, iron, lithium, acid or alkali, hydrocarbon, and cyanide. So, in these substances is no of value to use activated charcoal. And the second point is the activated charcoal is effective when given within the first hour of ingestion of poison. The other method of decontamination is the whole bowel irrigation. We do this procedure by instilling large volume 35 ml per kg per hour of a polyethylene glycol electrolyte solution. And there is certain indication for this procedures when slowly absorbed substance, and second is when substance not well absorbed by charcoal, example lithium, iron. Now, the second procedure is after GI decontamination is enhancing excretion. So how we enhance excretion? First, urinary alkalinization. For a drug that weak acid forming charred particle trapped within the renal tubule and excreted, we do this by continuous infusion of sodium bicarbonate, and the aim is the urine pH of 7.5 to 8. It is most useful in managing salicylate and methotrexate toxicity. The other way of enhancing excretion is hemodialysis, and the major indication for hemodialysis is salicylate intoxication, methanol and ethylene glycol and theophylline. The third method of enhancing excretion is multiple dose activated charcoal. The single dose is to enhance GI decontamination, while multiple dose activated charcoal is enhancing excretion. And the third is how to neutralize the toxin, which is antidote. Some point on antidote. Antidotes are available for a relatively few poison, thus emphasizing the importance of supportive care and those clinically monitoring. Early and appropriate use of antidote is the key element in managing a poison patient. There are some example of antidote. Example, the drug is benzodiazepine, the flumazenil is the antidote. In case of iron poisoning, the antidote is deferoxamine, chelating agent. Case of opiate poisoning, naloxone is the antidote. Paracetamol is an acetylcysteine is the antidote. And beta blocker, glucagon or adrenaline. And lastly, example, digoxin, we give Fab antibodies as antidote. Now we start give an example of common poisoning in children, drug poisoning or substance poisoning. For the drug poisoning, we take example as the paracetamol poisoning or acetaminophen poisoning. Also, we take the iron poisoning, and in substance we take the organophosphorus or cholinesterase inhibiting insecticide inhibitor, and also we take the kerosene poisoning. So we start with, in this lecture, the acetaminophen poisoning, which is paracetamol. Acetaminophen, APAP, if you have this abbreviation, it is N-acetyl P-aminophenol. Acetaminophen is the most widely used analgesic and antipyretic in pediatric. Most common cause of acute liver failure. Now, if we take paracetamol, how the metabolism? So if we understand the metabolism of acetaminophen, we understand how it cause intoxication. Sorry. So if we take acetaminophen, in the liver there is conjugation to sulfate moiety and conjugation to glucuronide moiety. And there is enzyme which is called P45. This converts to N-acetyl P-benzoquinone amine, NAPK, what we call NAPK. This is a toxic substance. So acetaminophen is either conjugation to sulfate moiety and glucuronide moiety, which is a non-toxic substance, or by enzyme P45 is converted to N-acetyl P-benzoquinone amine, which is NAPK. This is a toxic substance. In the liver there is a glutathione which converts this toxic substance to cysteine and mercaptopuric acid conjugate and become non-toxic. Okay? Now, pathophysiology of acetaminophen poisoning. The toxic metabolite, which is called N-acetyl P-benzoquinone amine, this is the toxic metabolite. Therapeutic dose. In therapeutic doses of paracetamol, the glutathione stored in the liver detoxify this metabolite. So this is in the normal circumstances. In acute overdose, deplete glutathione stored in the liver. As a result, the N-acetyl P-benzoquinone amine accumulate, causing this substance, this NAPK, accumulate in the liver, causing hepatocellular necrosis and possible damage to the other organ, example, renal, pancreas. The toxic dose of paracetamol in a single acute toxic dose, if giving or taking more than 200 mg per kg in children and more than 7.5 to 10 gram in adolescent and adults. In repeated administration of acetaminophen at supratherapeutic doses more than 90 milligram per kg per day for consecutive days. So it's either in single acute dose or repeated administration of paracetamol. Clinical and lab manifestation. Initially non-specific, which is nausea, vomiting. Thus, the diagnosis not based on clinical symptoms alone. So you have need clinical and lab. It require combination patient history, symptoms, and lab finding, which include liver function test, INR, serum creatinine, blood gas analysis, and lastly the 4-hour serum acetaminophen. What are clinical stages in a clinical course of acetaminophen toxicity? So there are 4 stages, depending on the time from ingestion. The stage 1 from half to 24 hour, from the half hour after ingestion to 24 hour after ingestion. And the characteristic of this stage, anorexia, mainly GIT symptoms, anorexia, vomiting, malaise, and the lab investigation normal, except for acetaminophen level. After 4 hours, as we mentioned, we check this acetaminophen level. The second stage is from the after first to 2 day, and in this stage, resolution of the aerial symptoms, right upper quadrant abdominal pain and tenderness, and elevated hepatic transaminase, aspartate aminotransferase more than alanine aminotransferase, and INR. The third stage from 3 to 5 days. Peak in this stage, the lab investigation, peak transaminase elevation occur, and the development of liver failure, multi-organ system failure, and this either death or recovery begin. And the stage 4 from 4 days to 2 weeks. This stage, resolution of liver function abnormality, clinical recovery precede histologic recovery. Treatment. ABC measure is the mainstay, so initial care is airway, breathing, and circulation. The second is decontamination. Either we use emesis, gastric lavage, and the activated charcoal is the mainstay of GI decontamination. And the third is the antidote. The antidote for treatment of acetaminophen poisoning is N-acetylcysteine, intravenous or oral, a glutathione precursor. So an acetylcysteine is a glutathione precursor. So give more glutathione to convert the toxic substance, which is NAPK, N-acetylcysteine amine, N-acetyl aminoquinone, NAPK, to a non-toxic substance. And this, we have to know some notes about Rumack-Matthew nomogram. And this nomogram, we draw a diagram which is plasma acetaminophen versus time, used only in relation to a single acute ingestion with a known time of ingestion. So this is the criteria to use this Rumack-Matthew nomogram. So in a single acute ingestion with a known time of ingestion. In this nomogram, we find either no hepatic toxicity, or in the red zone, which is possible hepatic toxicity and a probable hepatic toxicity. So we check the level of the acetaminophen after 4 hours from ingestion. And if the level below 150, this is no hepatic toxicity. So, and if the level after 4 hours from 150 to 200, this is possible, and if it is more, it is probable hepatic toxicity. Then the patient fall in either of the following. First, either we prophylactic, and this normal aspartate aminotransferase and acetylcysteine if acetaminophen on probable or possible hepatic toxicity. The second is hepatic injury, when the AST rises first, then the alanine aminotransferase, followed by rise in the INR and acetylcysteine we give. Third, acute liver failure. In this stage, if acute liver failure occurs, liver transplant is indicated. These criteria that indicate poor prognosis for acetaminophen poisoning. First, acidemia, serum pH less than 7.3. Second, coagulopathy, INR more than 6. Third, renal dysfunction, creatinine more than 3.4 mg per deciliter, and the 4 grade 3 or 4 hepatic encephalopathy. And thank you. By this we end the acetaminophen poisoning and we end the first lecture. And please, dear student, don't hesitate to ask me any question if you have, and thank you for listening.